There can be so many times when things get a little bit awry for women that aren't really menopause. So if you're thinking, I don't have any menopausal clients, I'll make sure you guys understand what some of these hormone changes can look like at other times. The long time without your period, that unexplained amenorrhea. Breastfeeding is another time of really low hormones for women. We've got a lot of prolactin and we don't have a lot of our other female hormones, and same thing with pregnancy, things are a little bit different. And a lot of women go through premature ovarian failure, so they're going through menopause truly at a young age. So we'll talk a little bit about that too. So what is menopause? Technically, the medical definition is when a woman hasn't had a period for 12 months. And what happens in terms of their physiology and their lab work is they're going to come to you and say, my FSH was really high. My doctor checked it, and now I'm in menopause. And that's one of the signals from our pituitary gland that tells our ovaries to ovulate. So as our ovaries wane and they're not able to do what they're going to do anymore, the brain literally just kind of tries to shout at it. So we start to see that FSH signal from the brain really come up, and that can be combined with the changes in their cycle. And obviously the end result is they're going to be lower in estrogen and progesterone and testosterone as well. One of the things we're going to talk about today is we think about menopause and we think about female hormones, and we really want to go towards estrogen and progesterone. There's a lot of stuff that fuels those to be more normal, which is your stress hormones and your blood sugar regulation. And those are the things you guys can have a lot of intervention with your clients. So don't get too worried about, like, I can't run a blood test, or I don't know if I can't prescribe this person hormones or herbs or whatever. We'll talk about the things you can do that secondarily will really affect these other female hormones. Obviously a little bit lower levels of testosterone as well. And then what happens with women as these hormones go down is all of their metabolic issues get worse. If they have insulin resistance, if they have adrenal fatigue or adrenal overdrive, those things are all going to get worse as their balance starts to shift, because estrogen and progesterone have a nice way of tempering some of that stuff, which is why when we were 20, we could just eat a little bit less and go jogging and everything was fine, right? Those pounds came right off. And not only does that work less effectively as we get older, as our female hormones wane, then it works even worse. And you'll have a woman say, I'm running every day, I'm hardly eating anything, and I've gained 7 pounds. So all of that stuff's going to really rear its head when women go through these transitions, whether it's menopause, pregnancy, or anything like that. So this can be a natural progression where the woman sort of gracefully goes through it and ends her fertile years and life goes on, or it can be total health. It can be really, really tough, and a lot of that's going to depend on their muscle mass, because that's sort of where our insulin sensitivity is. So we're going to have a better metabolism the more lean tissue that we have. And it's this perimenopausal time where hormones are going up and down. That's when women are really suffering the symptoms. But even when that's over and they feel a little bit better, they're still going to have the metabolic issues, because that's when those other hormones are really low. So perimenopause, again, that can last for 5 years for some women. And again, it's muscle mass that's really helpful, and their adrenal status, how healthy and fit and able they were to cope with stress when they got there. That's going to determine a lot how bad their symptoms are and sort of how miserable they are, and how much of a weight issue they start to have. As some women say, they just all of a sudden have this new thickness in the middle that they've never had before. And we'll talk about exactly why that happens. But the net hormone landscape in perimenopause is a little different. They're actually overall higher estrogen, lower progesterone, because what the body does is, your body's really smart, and it will start to find ways to make more estrogen as your own production goes down. You'll make more estrogen out of your body fat. You'll start to convert your own estrogens into the more active form. So that's when we get into, you're kind of low estrogen, or you're moving towards low estrogen, but you still somehow have all these excess estrogen symptoms, which we call estrogen dominance. So you kind of get the worst of both of those problems. So menopause, of course, is when they're both low, but this time in between can be really a mess for women. And they still get, again, when the fluctuations are over and the symptoms are better, they're still going to have some of the metabolic issues. So just heads up, there's a lot of women that think they're going through menopause. Their cycle gets a little weird, their hair falls out, they're tired, they're having hot flashes, and there's just a couple of conditions that can look like that either are common to occur at the same time, or they could be totally different. One of them is particularly Hashimoto's hypothyroidism. If any of you guys follow me on Facebook or anything, that's one of my main specialties. That can result in hot flashes, changes in your cycle, brain fog, all those things that women complain about during menopause. So it's always a good idea to make sure your clients or yourself is talking to someone to make sure they're looking at some of these other things, because it may not be actually menopause yet. PCOS is polycystic ovarian syndrome, another one of the things I treat almost exclusively. These women are going to have changes in their cycle, and this can depend a little bit on age, but some of this stuff truly doesn't show up in our younger years, and as we go through more stress and we get older and things get more out of whack, some of these things can either get worse or present themselves. And then there's premature ovarian failure, where a woman can go through literally menopause at a much younger age, and that's usually an autoimmune condition, but there's some other explanations for that as well. The amenorrhea, losing your period for off and on due to overtraining or undereating, those can happen as well. And sometimes age is a giveaway, but never assume, right? We don't want to assume that just because our client is 45 and she's experienced some of these hormonal symptoms that she's in menopause. I'm 8 years older than my husband, and when I was pregnant with my first daughter, I was 36, and his younger sister, I was there for Christmas and was late, and I'd taken a couple pregnancy tests and wasn't pregnant so far, and I thought, you know, we're out shopping for Christmas, I'm going to take another one just in case, because I know my cycle's really kind of weird, and it hasn't been this weird. And she's like, maybe you're in menopause. And I'm like, your mom's in menopause? I am not that old. So we don't ever assume, but I think that's part of how you're going to talk to your clients is really important, because older is just older, right? You just don't know, like I had no sympathy for new moms until I was one, and you don't kind of know until you go through those things what that feels like, to feel like your body is completely changing. So yeah, so don't ever assume we know what it is. At the end, we're going to talk about some kind of lead-in questions to get a little more information without triggering that response I gave her. So again, the severity of symptoms in menopause and how much of a tough time a woman's going to have really is going to depend on her adrenal health. So that becomes the backup mechanism. When our ovaries can't make hormone anymore, we start to rely on our adrenal glands. But stress always trumps all. So if you're really stressed out and you're in a kind of a weak place with that, you're not going to have a lot of reserves left to try to make those sex hormones. So as the ovaries go, they're going to have a really tough time. Muscle mass, of course, that protects us from not only osteoporosis, but again, that's a big metabolic reserve for how well a woman's going to do when they go through menopause and they lose these other anabolic hormones. So insulin sensitivity, those of us like myself with PCOS or any type of insulin issues or adrenal issues going into menopause, it's going to be harder for us because we're already sort of functioning at a metabolic deficit, and our hormones are a little bit unstable anyway. And then the ovaries will continue to make a little bit of testosterone. They can still do that. So if a woman, for whatever reason, has had her ovaries removed, they're going to have a tough time as well. So metabolic changes, we're talking now again, we're on the other side of perimenopause. We're looking at your client that's gone through this, and then what they're going to come to you and say is, my hips and thighs are a little bit better, but I now have all this stuff in the middle, and I've never had that before. They truly lose. The estrogen and progesterone are really what give us that hourglass shape. I'll talk about exactly why in a minute, but we lose that and we sort of go from like the hourglass to the apple. Things just kind of migrate up almost. So even if they're not seeing changes in the scale, they might be saying body fat's just moving into places it didn't used to be. So both of them drop, but relatively speaking, estrogen is going to be lower. So while production goes down on both, it's almost like if this is estrogen and this progesterone, and they start up here, it's almost like it looks like that. They're both lower, but the effects of the low progesterone are going to be much more prominent. Part of that is because, again, all those resources go towards handling stress. And that brings up more issues with estrogen dominance. So women see a little more cellulite. They see sometimes more of a struggle to lose the hip and butt and thigh fat. Thyroid are really both, estrogen and progesterone are both important for the thyroid in different ways. So we'll talk about that. So as those go down, the thyroid takes a bit of a hit. As you're going to see with all this, there's a lot of interplay. So adrenals go, ovaries go, thyroid goes, and you're almost always going to see multiple issues with the woman. It's rarely just they're suffering from hot flashes. And estrogen fluctuations in that perimenopause time can trigger things like Hashimoto's. So they may not have had a thyroid, but just the natural progression of this change can trigger that for them. So all of these things just to say that there can be multiple reasons why your client is now struggling with more fat loss, or we start to struggle more with fat loss. So back to adrenal health, I think I've driven that home. When we are overly stressed going into this, it becomes even worse because now we've lost that temperance of estrogen and progesterone, and everything that causes us stress is just a little bit worse. So we don't tolerate less sleep as well, we don't tolerate longer distance exercise as well, we don't tolerate overtraining as well, we don't tolerate undereating as well, we don't tolerate any kind of stress as well. So all of those things become why we have to help these women maybe train and eat just a little bit differently than they used to before. And they're all going to tell you that. They're all going to say, what I used to do is not working. And that's part of what we have to help them understand is it's not going to work. You really have to attack this from a different angle. Again, the low estrogen worsens both cortisol and insulin issues. So any blood sugar trouble that they have and fuel regulation is going to be worse. Any sleep issues that they have is going to be worse. And then progesterone, again, is one of the reasons that the sleep falls, and it's one of the reasons that stress is so much worse. We'll talk about the fat gain next. So why do they see this migrating to the middle? So what happens normally in our bodies is we have sort of an easier time as women putting on fat in the hips and butt and thighs and our breasts, because estrogen in those areas is really good at storing some fat. So that gives us those curves. And then progesterone does a really nice job of modifying the effects of cortisol at the belly. So when we lose the estrogen, we lose some of our curves, and when we lose the progesterone, we tend to lose our waist. So this happens post-pregnancy as well. If you're breastfeeding, you have really high prolactin, which is shutting off those other hormones. So women will see when they stop breastfeeding that they might struggle during that time to lose weight, and then they stop, and everything comes back, and they go back to normal. So even without a big change in the scale, again, you're going to hear that women will start to feel like their body fat is just moving to a different place, and they've got this fluff or a spare tire or something around the middle. I think I've hit both of those, so we're going to go on. So another thing that's really going to impact a woman's ability to, and this all of us, to lose fat is how well we're sleeping. And perimenopause and menopause can be a really tough time of sleep, because their adrenal issues, if they had any sort of stress problem before, is going to be worse, and that's going to affect our ability to fall asleep and our ability to stay asleep, or just the hormonal changes. They're having hot flashes and night sweats, it's of course waking them up more. And progesterone also is a really nice calming hormone, so when we lose that, we tend to lose a little bit of our ability to relax. So all of that to say, gonna have a harder time sleeping, gonna have a harder time losing weight. That's true for all of us, but this is a group of women that really struggles with sleep, probably as much as new mothers. You see worsening of cellulite, again, because we've got a shift in that estrogen dominance picture. Remember, even if estrogen's low, the metabolites or the type of estrogen we have around, coupled with the lack of progesterone, can make some of those high estrogen symptoms happen, even when they're overall low, and that can be a little bit confusing. And again, weight gain possibly because the thyroid could be impacted as well. So again, when we talk about menopause, we really think this is all about estrogen and progesterone. That's the big changes. But if we don't fix the cortisol and the insulin issues, and I'm going to talk about what each of those hormones do, so if you're not familiar with that, we'll talk about it. But if you don't fix that first, those estrogen and progesterone changes we make, other than giving them a pill of estrogen to take, we're not going to see a lot of shifts in the stuff you're trying to work with and have them feel better and have a better metabolism. Which is the good news for you guys, because you guys see these clients a couple times a week, and you can have a big impact on helping them sleep better, eat regularly enough, eat the right way, not be overtraining, getting plenty of rest and recovery, getting lots of walking. All those things are going to help no matter what they decide to do with their estrogen and progesterone, whether they decide to take synthetic hormones, bioidentical hormones, or herbs to try to help normalize it. All the stuff you guys do with exercise, diet, and lifestyle have to be done anyway. If they just get on herbs for this, they're gonna have still a really hard time with the metabolic issues if we don't address these things first, which is great because we all have a lot of control over those things. It's a little bit harder to control our estrogen levels when we go through our ovaries failing. So that's always the place to start. So even as clinicians, we get into this thing of like, I'm gonna go right after giving them some hormone replacement, and if we don't work on these other issues, they're still gonna not be doing very well. So again, menopause is a time when adrenal and blood sugar issues become worse, and that's something that's affected all day long for all of us in this room and every woman that you work with. You know, their blood sugar can be changed by how and what they're eating. So to give you a little overview of these hormones, in case some of you guys aren't familiar, cortisol is your stress hormone, your main one. You also have adrenaline, but it raises your blood sugar during any time of stress, whether you haven't eaten, you've been sleeping all night, you're stressed, you step out in front of a cab, you're late getting here, can't find your way, all those things. Fasting is another period of stress. And not to say that all these things are bad, it's just a question of how well can any of us tolerate it, which makes all of the things I'm going to say to you guys today, it all has to be viewed through your client's physiology. I might talk about they should be doing eating this often and they should be eating this many grams of carbs. But we always have to take the advice that us experts say and look at it really through what's your client actually going through or what yourself is going through. So if we've experimented with things like intermittent fasting works really, really well for some women. If you've got someone with adrenal fatigue, they're not going to be able to do that. So it doesn't mean intermittent fasting is bad, it means it's bad for that person. So just a good reminder that whatever you hear today, you're going to have to continue to filter that through the woman who's sitting in front of you. So cortisol, another thing it does is it's high inflammatory when it's around all the time, the chronic stress that we experience, but it's nice and anti-inflammatory in short doses, just like when you take a corticosteroid cream to calm down an itchy rash. In the little bursts, it is anti-inflammatory. So it's a good thing and a bad thing. It's just basically a bad thing the way that we have it nowadays. And it's necessary for your clients to recover. It's necessary for a lot of hormones to work better. Cortisol has a way of kind of activating lots of different receptors and making all hormones work better. Again, we talk about cortisol like it's really, really bad, and it is when it's around too much and too often, but this is just the basics of what it does. And it is necessary for fat burning, especially at those higher intensities. If we've got a woman who's really low adrenal and you're putting her through a metabolic circuit or some sprinting and she's not getting the results you want, she'll probably is not going to feel very good when she does that, but she might not be getting the response because her adrenals are fried and she just can't put out the hormone necessary to spark that engine. Insulin's the opposite. So cortisol, if you remember nothing else, remember it raises your blood sugar. Insulin brings it back down. So whether it's because you had a stress response and your blood sugar went up, or because you ate a meal and it went up, you're going to need exercise, or you're going to need insulin to get that back down. It just shuttles it from the bloodstream right into the cells. And that it's necessary to get glucose out of the bloodstream into the cell, with the one exception: it is not necessary when you're exercising. We have a special mechanism to grab glucose out of the cells when a muscle is working, which makes walking after a big meal or working out after a big meal a really good idea. So except for, like I said, the GLUT4 transporters are the ones that are kind of cool and unique to exercise. So in an ideal world, if there's insulin around, it's going to tell your body that you're full, right? You just ate, blood sugar went up, insulin went up. But what you'll find for most of us and most of the women we work with, this is not a well-oiled machine. We've had years of stress. A lot of women, we have years of dieting, years of over-exercising, years of yo-yo dieting, weight gain. You've got thyroid issues. Now you throw menopause or some of these other issues in there, and it's not always working very well. So most women, especially as we get older, most people, we have some degree of insulin resistance. This doesn't mean they have diabetes. This just means there's something in that mechanism. It's not working as well or as efficient as life goes on. So this is especially true with women with fat loss resistance. So we always have blood sugar problems when someone's having a really tough time losing weight. And this can be in a thin person or a heavy person. We think of insulin resistance as someone who has to have a lot of body fat. Definitely not the case. In fact, we can be under body fat and we can be stressed and work our way into insulin resistance. So it can come at you from both ways. So these issues will get worse with age and with time. And again, seen in almost all of our fat loss resistance clients. I have kind of done this slide already, so we're going to go ahead and skip it. So I'll talk a little bit about thyroid, because it does get triggered a lot during this time when our hormones are fluctuating. Things happen. Your immune system gets involved, and this can be just like pregnancy, just like puberty. A time of hormonal fluctuation for a woman can be a time to trigger some of these issues that they didn't have before. The estrogen surges are the main way that this can happen, but I recommend, and you should recommend to all your menopausal women, that they do get screened for Hashimoto's even if their thyroid levels look normal, because they may have the antibodies and can get kind of a jump start on getting on top of that before they're actually in a place where their labs indicate that they need thyroid medication. So low progesterone can take a hit on the thyroid. The enzyme that actually makes thyroid hormone in our thyroid gland is turned on by progesterone. It's one of the reasons we see that spike in temperature at ovulation. That's when progesterone goes up, and one of the things that happens, you get a little burst of thyroid output. And then the estrogen dominance can make the thyroid free levels, which are the active levels. You got to have enough free thyroid hormone to actually work. That can go down if we've got too much estrogen in the system. So all these things you can see, these are menopausal issues, but we call it crosstalk in functional medicine. There's all this interplay between hormones, and these are just multiple ways that a woman can be struggling to lose weight during this time. And blood sugar stresses are also really tough for your thyroid. Your adrenal glands and your thyroid kind of are playing a tug of war all the time to keep your energy up, keep your metabolism going. So when one is having a hard time, the other one jumps in as best it can, but eventually you stress it enough and neither of them are doing very well. So a menopausal woman typically looks like this. They've got stress issues, they've got low hormones overall, but they're getting some of those high estrogen symptoms because estrogen is still higher than progesterone, insulin resistance to some degree, and all of this is sort of anti-thyroid. An easy way to remember it, menopause is anti-thyroid. So just FYI, what I said in the beginning, Hashimoto's really can mimic menopause for a lot of women. So if you see this list of symptoms, these could be symptoms truly of adrenal fatigue, they could be symptoms of Hashimoto's, or they could be symptoms of menopause. They're just really commonly thought of as menopause. So when the woman starts to have these, she's kind of depending on her age and what her body's feeling like, this can be a time where she just assumes that's what's going on, or we assume that's what's going on. So I just like to remind women to take a look a little bit bigger. So let's get in a little bit more to what estrogen does, because estrogen in our industry gets a really bad rap. We talk about estrogen dominance and cellulite and being fat and all this stuff, and we blame estrogen. And to a degree, that's all true. Estrogen dominance is a thing, but there is a lot of really important things that we have estrogen for. It's really what gives us, our libido. So if you think puberty, we start to get really interested in boys and having babies, and all this stuff that happens is thanks to estrogen. It evens our mood. Estrogen boosts serotonin, boosts dopamine, and it's our anabolic hormone. We do have some testosterone, and it's still anabolic for us, but we don't have anywhere near the amount that a man has, so this is really how we put on our lean mass. And it's protective, of course, against heart disease and osteoporosis. It's anti-inflammatory as well, and it does help, again, aid the insulin and cortisol, all that blood sugar mechanism. Some of the bad stuff that can happen is really tempered and balanced by estrogen and progesterone. So it makes our metabolism a little more forgiving, which is why we always say, when I was younger, I could do this, I could do that, I could drink every weekend, and now we try to do any of those things, and it's just not the same. And a lot of that is due to when our estrogen starts to go down. And it really does start to go down starting at 35. We start having less effective ovulation, and not that 35 is anything like menopause, but things do change. And again, it all depends on the woman that you're talking to. So this is our feminine hormone. It gives us soft skin and full hair, all those in our round hips. And I think Marilyn's sort of the poster girl for healthy estrogen. She's got lots of curves, tiny waist. So that's really what our kind of feminine figure in terms of our hormones looks like. So it aids fat loss, especially at lower intensities. So it doesn't do much for us during high intensity, but estrogen is part of fat metabolism for walking, yoga, running, like jogging, not sprinting. So it's important for those things, and we're going to lose that effect when we have less estrogen. The problematic estrogen metabolites in the with the low progesterone, those can really get in the way of fat loss. And as estrogen goes down, those things are going to go up because our body really likes to keep things going the way that it was. So when our estrogen starts to go down, our body knows one way we can get more estrogen is to put on more body fat, because we can make estrogen from that. So again, you'll start to see women just, even if the scale weight doesn't change, their body composition will start to change. And then we've got this other interesting thing that happens with estrogen and fat metabolism. Our hips and thighs have more of a certain kind of receptor that responds to adrenaline. So we always talk about getting at good fat burning from high intensity exercise and sprinting. That is done through the beta receptor, and women have more of the alpha receptor. So we're just naturally predisposed to being worse at burning fat in these areas. So again, that'll shift a little bit with menopause, but it's just one of the important things to remember about why some of your clients, regardless of menopause, might be struggling to just lose this particular fat. We are just sort of geared towards keeping it there. And we'll talk about a couple ways to actually block that and get a little better effect, but that's why we have this. And I had to put this one in because we have our hourglass women lifting some, they're not that heavy, but we'll cut her some slack with that. So another way that low estrogen can really impact a woman's weight issues is that it has a lot to do with cravings and appetite. So the low estrogen is going to, of course, make those insulin and cortisol symptoms worse. And when we have blood sugar issues, we have cravings. If you miss a meal and you get that insatiable appetite, that's going to get worse. If you're someone who gets sleepy after they eat, and we've got insulin issues, those are going to get worse. So we get some dysregulation of appetite, and women can't quite control their cravings during this time. And real quick, I write about this a lot on my blog, so you can check that out if you want to see more of blood sugar things you guys can do. But signs of low blood sugar are always going to happen between meals. You're going to see sugar cravings or really hungry. All that stuff's going to happen between meals. Poor memory, irritable, shaky, all that stuff between meals. That's someone dealing with low blood sugar. The signs of insulin resistance, so now we're having problems with high blood sugar, that's always going to happen after. So when someone tells you they're having a lot of cravings, you want to ask, is it between lunch and dinner? Is it that I have to have something sweet every time I eat? And that's how you know which side of the seesaw they're struggling with. Another hormone that gets involved here is leptin. That's sort of our appetite and hunger signal, and estrogen helps that be more balanced. So again, when estrogen goes away, we're going to have more cravings and a harder time regulating our normal appetite. And low estrogen, again, usually means low brain chemicals like serotonin and dopamine, and we know when we have low serotonin, all we want is chocolate. And when we have low dopamine, we want carbs and coffee. We want stimulants. So estrogen dominance I want to talk about a little bit, even though menopause is mostly low hormone, because this is one of those things that I feel like in the fitness industry has got really talked about in a way that almost doesn't even make sense to us anymore. And like I said, we've all kind of started to hate estrogen because of estrogen dominance. So all this truly means is when estrogen is high when it's not supposed to be. So if it's the second half of a woman's normal cycle, that should be a time of high progesterone and not estrogen. So if you look at that graph, cut that in the middle, let's say this is a really normal cycle. Obviously this doesn't happen for most women, but right in the middle there at day 14 would be when a woman ovulates. And that's sort of the breaking point between the two. So the first phase of our cycle should be high estrogen. So technically we're in estrogen dominance the first 2 weeks all the time. It's not a bad thing, it's supposed to be that way. Second half of the cycle, estrogen should go down. We should have, from a nice healthy ovulation, a big bell curve looking thing of progesterone. So estrogen dominance can be when there's too much estrogen that second half, when it's supposed to be nice and high progesterone, or it could be like a woman with polycystic ovarian syndrome where she's spitting out estrogen inappropriately the whole time. Or it can be what we talk about a lot in fitness, which is problems with estrogen metabolism, leading to the bloating and the trouble with our skin and trouble with fat loss, trouble with insulin resistance, and that is cellulite. That's all more the poor estrogen metabolites. All those things to say, when these two things are out of whack, it's really easy to have a lot of trouble with things that just kind of crop up that weren't there before, right? What we were doing before, different times in our life, now things don't work as much. So again, estrogen should be high the first part of the cycle, and that estrogen dominance is an okay thing. Another reason we get a lot of estrogen dominance now is because we have so many estrogen-like chemicals in our world. We have hormones in our milk and our food, and they're coming at us from all different sources. And again, we can make them in our body fat. So we're in a very estrogenic world that we didn't used to live in. So all of that is part of fat loss as well. So quickly on progesterone. Progesterone does not have as much to do with sort of revving up your metabolism or being a big fat loss hormone the way estrogen does, but it's the kind of nice dance partner, whereas estrogen's trying to run the show, progesterone does a good job of keeping her in check. So we lose that when we start to lose our progesterone. And going through menopause, the progesterone's going to fall first because, again, we go back to the stress that a woman's been under over time. And when our resources, we make all of our sex hormones and cortisol out of cholesterol. So when we go through these times when we need more progesterone and we've got a weak adrenal system, we can't sort of support that system that's failing. So think about PMS. When we don't have a lot of progesterone, we go through that dip right before our cycle starts and we can feel like a crazy person. You can feel bloated, you can feel fat, you get a lot of water retention, not really fat. And then again, stress. When there's a problem of resources, progesterone is going to be one of the first things that fall. So again, it doesn't really do much for actually revving up our metabolism, but it's important to kind of mitigate some of the effects of the other hormones. So progesterone and fat loss, we've talked a lot about how it tempers cortisol and insulin, and those are big regulators of our fuel, but it also gives a nice boost to the thyroid. That will go away. Again, the low progesterone leads to a lot of water retention. Some women will gain as much as 5–10 pounds coming into their cycle. Those women are having, a lot of progesterone estrogen issues at that time and holding a lot of water. They get their cycle, it all goes back to normal. So women going through menopause, as they go through these changes, can get that water retention too when the progesterone goes away. And it's not really fat, but no one likes to feel bloated and holding on to a lot of water. Progesterone also boosts GABA, which is what I call our natural chill pill. And so when we don't have that nice calming GABA around, we can definitely have more cravings there. So you're going to see some of this stuff is just hardwired into the metabolism, and then a lot of it is behavioral. You're having a hard time regulating cravings that you used to be able to control when you lose these hormones. And so the summary of all this stuff, kind of the takeaway, is that overall estrogen makes us leaner and tighter, gives us the hourglass shape. And then progesterone keeps cortisol and insulin from having that effect where we get the belly fat. So one thing I'm going to talk about in a minute is the kind of recipe for belly fat is both, we talk about it being stress, but it's high insulin with high cortisol. So we've got high stress and too many carbs for that particular metabolism. So low carb, high carb is really all relative to how well our body can handle that. So we lose the effect of those hormones to mitigate that, which is why women see more weight gain around the middle. So the net effect is we lose our waist, we gain a belly. Overall, we have a lower metabolism, and sometimes their hips and thighs will lean out a little bit. Testosterone's part of the equation, but it's not as important as the estrogen is for our own muscle mass. But if you think about it in terms of when they go through menopause, they're losing everything. So we're losing the estrogen and the testosterone. Women can make a little bit of testosterone still in their ovaries. We just don't put out enough to compensate for that lack of estrogen. And again, going back to adrenal and stress issues, you're going to have a lot of women who are low testosterone also. So even though they're low testosterone, just like they can be low estrogen and have high estrogen dominance problems, you can be low testosterone but have testosterone metabolism problems, so women will start breaking out again going through menopause. They'll start getting like wiry hair growth in places they don't want it, like their chin or their lip or their lower stomach, and it kind of feels a little bit like puberty all over again. So what we can do, we can't do a whole lot for testosterone for women, but women do get a good growth hormone response during high intensity exercise, and you can maximize that. So they don't get as big of a testosterone response. Men burn more during, we tend to burn more after, because we get a nice push of growth hormone after intense exercise. So that is something, again, back to the things you guys can do that can help them. So here's what you guys are here for, right? Now that we got the background of what all these guys do, what do you do about it? So they're metabolically less efficient, and they just aren't going to be burning as many calories. And you couple and layer on more issues. They might have a thyroid problem, an adrenal problem, a blood sugar problem, and now they don't have enough estrogen either. It can be a really pronounced shift in their metabolism. So nutritionally, because they are now less insulin sensitive because they've lost the effect of those hormones that supported their metabolism, they're less forgiving to carbs and sugar. And with exercise, they are much more stress sensitive, mostly because of the drop in progesterone, and they are going to be more sensitive to over-exercising and overtraining. But what does every woman want to do when they start to gain weight? They want to kind of dig in deeper, and they want to, eat a little less and exercise more, and they're going to come to you and say, I added a couple workouts, I really cut my calories last week, or I really cut my carbs last week, and I've gained weight. And that can be a really maddening thing, which is when they end up in my office because they're completely unsure of what's going on. So the stress sensitivity means really that low-calorie diet and the over-exercising, they're just going to be much more sensitive to it. It's going to be a lot harder for them to recover from. So what you'll hear is I used to just go running to lose weight. That's not working. I'm eating less and gaining, which is one thing to eat less and not get results. It's another to eat less and start gaining weight. And I've never had this much fat around the middle. I used to have maybe bigger hips and thighs, but I've always had a tiny waist. Everything seems like it's changing. And again, even if they didn't gain any weight on the scale, they're gonna really feel like things are just shifting around and moving and their body's really changing. And any of these hormonal issues, women often feel like, my body's just betraying me. I'm trying so hard, I'm doing so much, and I'm just not getting anywhere. It just can't, it's like it's abandoned me. And that's never a good way to feel. So my menopause nutrition template, and again, all this advice has to be taken into account of the woman sitting in front of you. And to me, the term low carb it's all relative. So low carb for me might be way less than a low carb diet for Cassandra, might be way more than a low carb diet for Molly. It's all gonna kind of depend. So we have to kind of get out of that idea that low carb means they're having 10 grams of carbs all day. It's just lower than they have been eating now. That's the place to go in, because They're less insulin sensitive, so we know they're not tolerating that food as well, but also using that because they've got a little insulin resistance. We talked about one of the things that happens when that mechanism doesn't work is they get more cravings. So if you can go in to reduce calories by reducing carbs, their cravings level out just a little bit. So you want to keep their veggies nice and high, and you want to keep their protein nice and high and their healthy fats, but that's sometimes a way to just take them down by start with 25 grams, start to just kind of work with it and see if you can get things to budge. For most women, if you're not sure, you can kind of start with like 100 grams-ish, which is going to be pretty low for some people. And again, this is completely for fat loss. This is when the woman's coming to you saying, my goal right now, I don't want to lose my muscle, I want to stay strong, but I'm not trying to train for an event, I'm not trying to perform, I want to do whatever will tweak my metabolism a little bit to get things going. And we'll talk about the mechanism of why, but because of that insulin issue, this is the way to get in and get things moving. I call it their unique carb tolerance. Again, I'm back to saying that low carb is all relative. So for me, I might be able to eat a half a cup of a certain type of carb, and then I get sleepy and start having blood sugar symptoms and cravey and all of that, whereas someone else might need a cup and a half of that same food before they get. So you can use those symptoms. They're on that slide prior to that. Where are they getting symptoms between meals? Are they getting symptoms after? When you're getting sleepy afterwards or craving afterwards, or you've just eaten a meal and I just want to eat more, I just want to have more food, then you know you've overshot your insulin capacity. You can also have people get a glucometer and really dig into the numbers. 2 hours after eating, their blood sugar should be back to like 100. So you can kind of play with that. But the reason I do this with women and teach them to use those symptoms is because it changes. They're, 6 months from now, they might need more or less. So if they can read those symptoms, they can start to adjust this on their own. And then my acronym for are your hormones in balance? So we're going in through lowering calories via lowering carbs. How do we know we've gone too low? Well, their appetite, their cravings, their energy, or their success. So are they losing or not? When those things are out of balance, their hormones are out of balance. So you know if they're eating, let's say 100 grams of carbs a day, but their cravings are crazy, they can't get through the day, it's too low. So that's one way to just teach them to use those symptoms as biofeedback. So how often to eat? To me, this is another really individual thing. So start them where they're at, make some adjustments in the carbs, and if they're having a struggle with, because we have so many nutrition rules, right? Can't eat after 6, can't eat after 11, you gotta skip breakfast, and women we get really married to those rules, especially the ones that worked for us. They can be really scary to now, like I'm in a time now where I need more carbs, and it scares me, because they used to just make me fat, but now it's a whole different thing with breastfeeding and my hormones are in a different place. So what has worked for these women before, they can be really, really scared to let go of that, but gently nudge them and explain to them that if their appetite, cravings, and all those things are off, their hormones are definitely off and their metabolism is not running even the way that we think it should be running. So protein, sometimes for women, shakes are an okay thing. As a naturopathic doctor, I like real food, but that can be something that really works for women. A lot of times women with adrenal issues that are going to get worse when they go through this change have a really low appetite for protein. So us telling them to eat an omelet or a steak or something for breakfast, they can't do it. So that can be a time when shakes can work. And it's with insulin resistance, some women can overdo protein. We always just keep, when someone's having a low carb diet, we'll just pump them full of more protein. If they get those cravey and appetite dysregulated signals after eating, that's an insulin response from the protein. So just watch that. If you think this doesn't make any sense, they didn't have any carbs, but they're still having high insulin symptoms after they ate, they might be someone with a lot of sensitivity in that mechanism, and even the insulin required to metabolize the protein is too much for them. The best way to deal with that is just give them more vegetables. So we definitely don't want women walking around being hungry. And one thing I want to drive home, but before I talk any more about low carb, is the ultimate goal is always to have a woman eating as much food as she can and working out as least as she can to get the results that she wants. And women aren't inclined to do that, right? We're inclined to work out more and maybe eat less or cut out different things. So that's the end goal, but sometimes to spur things, we have to play with it a little bit. If you take them to a lower place and their hormones aren't liking it, they're getting more cravings, you've got to bring them back up. So why the lower carbs? The lower carb diet will work for these women because they're losing, again, that estrogen progesterone balance for their insulin. And this is a way, the low carb diet will enhance that alpha and beta issue that we talked about. So that can be a way that they can get a little bit more fat burning, because we have to dip into more fat metabolism when our carbs are really low with those high intensity workouts in terms of their adrenaline response. So menopausal women, low estrogen, they're going to have less of this issue here. So you are going to be able to manipulate that a little bit. And in my experience, this includes dairy. When we talk about low carbs, a lot of women get a big insulin response from the casein or the whey that's in dairy. And cravings and appetite, first get their blood sugar balanced. Next, dopamine and serotonin can be off, and sometimes this is a way you can use cocoa powder to deal with their cravings. This is something I've done since I was in school at Bastyr. This can be overstimulating for some people. Some people, if they have this at night, they feel a little wound up. Not so much from the caffeine, but because this can trigger boost their dopamine, and they're having a hard time. Dopamine is a nice stimulating, motivating chemical. So I usually use some sort of low carb sweetener if they can tolerate it, because cocoa powder plain is quite bitter. But that, again, this group of women, they have a lot of cravings. This is really a time of dysregulated appetite for them and cravings, and they're not able to fight it. And this is a tool that can work pretty well. Watch this late in the day, or if a woman's got an autoimmune disease, cocoa is a nice stimulator to the immune system. So it might help make them feel better, or they might say, I really feel terrible when I have all of that cocoa powder. So that can give a little insight into their immune system, but just watch that. If someone tries this and feels terrible, that may be why. I'll also a lot of times give women amino acid capsules between meals to kind of keep their nutrition up during this time, and that can also help with the cravings. They're getting just a little float of amino acids to feed their brain in between. I use a product called Amino Acid Synergy from a company called Designs for Health, which in this day and age you can find anything on the internet. That is a doctor-only brand, but you can find that there. And I'll usually have them maybe do 3 or 4 between meals, and that really takes the edge off those between meal cravings if you think that you've kind of dealt with the blood sugar issues. Sometimes instead of loading them up with a higher carb intake after a meal, you can use branched chain amino acids to do this enhanced recovery but not give them as many carbs and stress their insulin mechanism as well. This again, sometimes with that, you'll see a big spike in their cravings, and that's again someone that's probably got a lot of insulin trouble. So dopamine and serotonin support, things that support those neurotransmitters will of course help balance their cravings. So L-tyrosine boosts dopamine, 5-HTP boosts serotonin, SAMe and St. John's wort both boost serotonin. Quinopurins is a chemical that will boost dopamine. And you sometimes find these products these new ingredients in a combo product for brain health. And then GABA, remember GABA can take a dive when progesterone is low, and that's all those calming herbs like valerian and chamomile and things like that. I have a product called Calm Plus Sleep that's GABA support on my website. And again, these women are gonna have a lot of sleep trouble, so anything you can do to help them sleep better, balance their blood sugar, lower their stress, maybe don't have them work out in the evening anymore, anything that helps them sleep better is gonna make your job easier. So the template for what to do with them for exercise, and again, these are called templates because it's a place for you guys to start, but it may not be, the perfect thing for your client. You're gonna have to tweak it a little bit. So we don't want them to exacerbate the issue with the wrong exercise. So again, they're gonna be inclined to start doing more, especially if they've been someone who really loves doing a lot of cardio. This might be a time where that's really, really tough for them, and that will make things worse. You're gonna wanna enhance rest and recovery. And then you've got to work with the current hormonal landscape. So this isn't the same things they could do when they were younger. This is skipping probably the long duration stuff and the long duration high intensity stuff. Walking is great. Strength training has to be just heavy enough. And metabolic work, if they can tolerate it. Again, this is all going to depend on how fit a woman's stress response is. And lots of walking. A couple ways to enhance their calorie burn from walking. Walking is one of those great hormonal resetters. It's going to lower their cortisol, it's going to help their insulin, it's not going to do anything bad. And one way to get it to burn a little more calories is to have them do it fasted in the morning if they can, for 45 minutes an hour. Have them do maybe 20-30 minutes after a strength training session, so they've liberated all that fatty acids from your really smart workout, and then they can walk and burn that off. And back to the growth hormone response, again, from sprint training, women do get a pretty good growth hormone response after the fact. So that is a really good way for us to enhance what we do still have left to work with in these women. So we want to avoid the long, intense stuff. We've talked about that. What if a woman really loves it? It's really hard to say to a runner, you can't run anymore. Try to keep it in a little bit. Try to let them have it a couple times a week while you're doing the other things. But what trumps that is if they're starting to get injured more, their sleep and stress are getting really whacked out, sometimes they do really have to give that up. At least till things settle and they get in a better place, they lose the weight, then they can try to go back to it. It's just, again, you got to kind of work with what they have. Now, if a woman comes to you and we really want to help them lose weight, but they would much rather just go running, we have to respect that too, right? Our clients don't always have the same goals that we have for them. Loads and loads of walking, that's always going to be safe, kind of as much as they have time for. And then enough sleep, meditation, this is a really good time to take up restorative yoga and do some of those things. So those are all kind of movement things you can do, exercise that are going to be hormonally resetting. None of that is going to mess things up further. Strength training, of course everyone in this room knows this, but this is a big, big must. They are overall less anabolic and less metabolically active. And of course we know this helps with our bones and helps us live a healthier life as we get older. So the template, if you're not sure where to start, you know, because I'm not sure how many people here are training and how many people are here for their own information, or you may not work with this population, but you know someone, or you work with, say, like Jessie works with postnatal women. She's probably not training a lot of menopausal women, but her aunt or her grandma may ask her. So a good template is have people doing some safe strength training, whatever their body can tolerate for weight, full body, 3 times a week. Doesn't have to be crazy if this is all new to them. And obviously take them where they're at. Most people in this room really respect and love and appreciate lifting heavier weights. Sometimes standing up out of a chair is where these women are at. So we still want to get them to a place where they can tolerate more, but you gotta get them safe and healthy for the long haul. I've talked about the growth hormone response. Again, if you're kind of coaching someone not sitting in front of you and you want to give them a template, kind of the sweet spot for getting that responses we're trying to get and not overly stressing is that 12 to 15 rep range. So telling them it's got to be heavy enough that you can't lift it 16 times, but not so heavy that you can't lift it 12. And you want to pay attention to tempo. I am so guilty of this. I don't think there's anyone in here who's actually trained me. I am like speed trainer. I never want to slow down. And they really do want to feel the burn in their muscle. That's some of those hormonal signals are happening when that shift is occurring. So that it needs to be heavy enough and they can't be doing it super fast like I like to do it. And then starters. This can be another thing to kind of boost things in their favor, is doing some sprints beforehand. Sprints may be for them walking upstairs, or it may be a full-on sprint, rowers, squat jumps, burpees, anything like that, whatever they can tolerate. 8 to 10 minutes of that can, again, get you into that growth hormone place. Then you strength train them, and maybe if they can walk afterwards, that's even better. So sleep and stress, I think I've talked about this. For the sake of time, I'm going to go ahead and move on. Metabolic conditioning. So now you've got them walking, got them paying attention to what they're eating, you've got them strength training. The next thing to do, if they can handle it, is to start doing some of the sprint work. So again, that may be like what I'm doing right now, which is literally walking up a flight of stairs a whole bunch of times and working their way till they can run up those stairs. So any kind of metabolic work that is at this point, especially if they're doing other strength training, this might be a little less of like a metabolic conditioning circuit and a little more of the like sprint type work. And this works again because we get this release of adrenaline during that time. And this is where the low carb thing plays in quite nice. So we get a better fat burning effect with the low carb and this, what they can handle in terms of that metabolic work. So you want to get them warm-winded and want to stop. That's a sprint. So it doesn't have to be running a 100-yard dash. It can be, again, for someone, body weight squats, rows. They just want to feel like they're getting warm and they don't want to keep going, right? A sprint should make us feel like we don't want to keep doing this forever. Sometimes with your really out of shape clients, you can do this on the ergonomic bike, especially women that have low back issues, which can be an issue in this age group for sure. Do you guys get these presentations? Cass? Okay, so I'm not going to go through this. These are just doses and some things that can enhance that adrenaline response during those workouts. I'm also not going to go through this. And these are just some things that help with estrogen detox and estrogen fluctuation, so those symptoms of perimenopause. And then progesterone support. A lot of women get prescribed Vitex to boost progesterone. That's not going to work in this group of women because they're not ovulating. So just if you've got a woman doing that and she feels like it's not working, that's why. So what about HRT? Do they want to get on hormones? That's a little outside of your guys' realm, but it's not going to really affect those metabolic issues. It's not going to change the insulin and cortisol picture, so you still want to do all of that work, and you still don't want them to be ignoring the overtraining and the undereating and all of those things. So they'll definitely help with the symptoms, though. If a woman's really struggling with her symptoms, that might be the way to go for her temporarily. Some women are going to tell you they're taking hormones and it's not working. Just to remind them, if they're taking topical hormones, rotate the site. They don't get told that a lot. It does build up in their skin. That might be a way to get them a little more effect. Certainly have their doctors take a look at their dose, but that's a really, really common thing I see with bioidentical hormones. And they really need detox support during that time. I listed one of the products I use for that. So all of that estrogen and progesterone talk to say that you have to still go back and deal with the insulin and cortisol issues, which you guys can all do. And what does this mean for women? Hormonal changes, pregnancy, breastfeeding, menopause, perimenopause, women can really feel like a stranger in their body. They lose their sense of identity. They don't feel sexy. They don't feel attractive. This can be a really, really tough transition. And they feel like their body is betraying them. They're trying. It's not working. And there are a lot of times where women are really good at asking, what's wrong with me? And then they come to us saying, what's wrong? I need you to fix it. So focus on insulin and cortisol, because that's what you guys all have control over. But explain the reality of what these waning hormones is. This is a tougher battle, and we do have to do things a little bit differently. And not to discourage them, but a woman can't go in, try to train and do what she used to do during menopause, because it's probably going to make things worse. So just help them understand it's not doomed to never look good and feel good again. It's just we have to tackle this in a different way. And it reinforce what they can't do anymore. And I think being honest with them eases the frustration. If we try to just tell them, we'll just fix it. I know all about hormones. I know all about how to metabolically condition you and get in there and get fat burning. That's not necessarily work for them right away, and sometimes this takes a little finessing, and that can be really struggling. But now they know what's wrong. It's kind of my motto at my office is when you know better, you can do better. And when you didn't know, you can't beat yourself up for it because you just didn't know. So how to talk about this. Avoid what my sister-in-law did and jump right to, are you in menopause? Because she might not be. So kind of get in by asking about their hormones rather than just using that word. How's your energy? How's your cravings? Take what we talked about here and start to know, have you noticed a big shift in cravings? Or you notice your body fat is changing to a different spot? How's your sleep? You ask women how their sleep is, she may say, well, I'm having all these hot flashes and so I can't sleep, but she may not have thought to really bring that up to you guys as part of her fat metabolism issues. How's your mood? That can bring up, they're feeling hormonal, they're feeling kind of crazy, I feel like I have really bad PMS. So just use those questions or ask them how their cycle. So women clients are probably going to be more inclined to tell you guys this than their male counterparts, and it makes the guys a little uncomfortable anyway, so they may not even ask. So try to get in there with asking about some of their symptoms. And they have a lot tied up in this. You know, their youth, their beauty, and a lot of us, our value comes from how we look, which is sad, but it's true. So you might be talking to a woman where you're trying to say, this is not this big a deal. Every woman goes through this. That's not what she wants to hear. She wants you to help her kind of go through this gracefully. So we don't want to gloss over how sad this can feel for someone and jump right to, well, I'm just going to put you on some sprints, take away your carbs, and it's all going to be better. So anytime we go through big changes, it's really hard. They, again, feel like their body's betraying them. And some of this, you might see these same symptoms in a woman who's 35. It's not really menopause, but she might be having ovarian failure, and it's going to be even harder for her, right? Because we all expect to go through this when we're old. We don't always expect to go through it when we're younger. And in my experience, a lot of women need to hear that's not their fault. It's their hormones, not your fault. Doesn't mean we can't do anything about it, but we are so good at beating ourselves up. So the last thing to do is, of course, assure them that it's not hopeless. They're not doomed to be in a body that they feel like isn't theirs. It's just a little bit, the way we have to go about getting it now is a little different. So I think I have used up all my time. Do I have time for a couple questions if there are any? Yep. Okay. Questions? All right, let's start over here.
So, like, myself, I had a partial hysterectomy. So I'm not, you know, I have my ovaries, but yeah, I can't gauge, you know, I don't have a period anymore.
Right.
So how do I know, or even people, like friends I talk to that deal with that, how do I know what?
Well, you're going to have to look at those other symptoms, right? What else is changing? All of a sudden, do you feel different? So if you've just, a woman who's had a hysterectomy may have both her uterus and her ovaries taken out, or just her uterus. And if anyone has the option, tell them to just, their doctor oftentimes says it doesn't matter, but ask them to keep their ovaries as long as they can, because then you can still make hormone. So you would still want to do adrenal support. You'd still want to watch your blood sugar symptoms. You're still going to want to watch those other symptoms we were talking about, like hot flashes and changes in where your body fat is going. And a lot of women describe menopause as really bad PMS. So when you just start, you're not having a period, but do you have any of those swings where you feel like I'm more hormonal now, even if it's, and your body should still be going through a cycle, right? You're just not having a uterine lining buildup and a bleed. So just trying to be in tune with those and watch if any of those are changing. It is.
When you're like, oh, maybe that's why I was crazy last week.
Yeah.
Now I know.
Yeah. And women that have things like PCOS that aren't having a regular period, they go through that too. They're like, I don't know, I think I maybe kind of sort of had PMS last month, but I didn't have a period. So there's a lot of women in that place, and women are really intuitive. You just got to remind them that those signals are important to listen to. Anyone else?
Okay, so say you have a client who is a new client and they're in menopause, they're not happy with their body. You get everything figured out. I mean, best case scenario, right?
Mm-hmm.
But say you did, I mean, can they have that pre-menopausal body that they have in their mind, or is there some middle ground that you need to make?
Jesse and I talk a lot about this with pregnancy. So when women go through these changes, the idea that we're going to get back to the body we had 5 years ago, it's kind of just sets them up for failure, right? We can't also go back and, unhave a baby or ungo through puberty. It is different now. So it's a different great body. Again, if they lose estrogen, their hips and thighs might be smaller now, and their waist might be bigger. So they have a different body, but it doesn't mean you can't get them leaner and healthier and happy. But again, I think if we try to say like, we'll just fix that and you're gonna look like you did when you're 30, we're setting them up for failure, and then it doesn't really allow you to do the work you need to do, which is work with what you've got now. So we have to tell women that in a way that's not like, well, you're just not gonna look good anymore. No one wants to hear that. So what they hear though is, they hear from their doctor, it's too bad. You're just older now, get over it. What they hear from some of their trainers is like, I'm gonna fix it. You're gonna look just like you did when you were 16. And the answer is somewhere in the middle. So that's where the coaching and the counseling and all those other skills that are so important to all of you guys that no one taught you when you learned to be a personal trainer, right? So you do have to kind of work with what you've got, but you definitely can get them in a healthy, leaner, happier place.
I think it's good to educate them up front so they know what to expect.
Yeah, and also it's important for them to know, because what happens when you start working with a woman and they do a little bit better and they're following everything you say and they're like, I was feeling really good, so I started running every morning before I got here, because I wanted to do just a little bit more, or I know you told me I needed 200 grams of carbs, but I only had 50. They're gonna kind of do some of those things to, we all are encouraged by results, so explaining to them the reality of the situation helps them maybe not go to that place where they wanna just, I don't know what it is about us, we always wanna do just a little bit more.
How do you relate this to amenorrhea? You kind of touched on it a little bit. Would you do the same, lowering their carbs a little bit and sprint work, stressing the body?
Potentially. And again, all of that stuff has to be taken into account with how healthy is that person. Are they someone that they can't hardly get off the couch, they're dragging themselves to their workouts? Their adrenals probably aren't good. I mean, ultimately, they could be working with someone who looks at them like I do, where they're getting that addressed and they're going to see you. Then they would know for sure. But, looking at what symptoms do they have of adrenal issues, can they handle that work? The low estrogen, so this is true whether they're, with amenorrhea, it kind of depends on the cause. It could be PCOS, it could be the hypothalamic amenorrhea, where their body fat's already too low and they're in a really stressed out place. But with breastfeeding and menopause, they should be able to, this should be the way to go. Again, provided they're not in a really bad adrenal spot. So you kind of have to just take that on case by case. And again, if you cut their carbs or change their exercise, their cravings, their appetite, their energy get worse, or they gain weight, then it's too low.
I have several clients who have had experience with long-term birth control, and they have symptoms similar to this. Would this be the kind of protocol you'd follow for that?
The pill kind of overrides all this. And part of the thing to remember is ask a woman, why were they put on the pill in the first place? I got put on the pill at 16 because I think I complained of like a cramp or two, and it turns out I had PCOS, but no one really looked at that. They just put me on the pill, and so I was just on it forever. Some women get put on the pill so their skin is better. So if they went on the pill for hormonal reasons in the beginning, they have breakouts, their cycle was erratic, really, really bad PMS, endometriosis, any of those things, they've got hormone issues, so ask why. But the pill is going to dysregulate this whole thing, and they are higher estrogen when they're taking the pill. Some women gain weight on the pill, some don't, and that all depends on how much progesterone they had to begin with, and again, their adrenal status. So the pill can be kind of a dicey subject.
Is there a rating when you go off the pill?
For some, there is. Yeah. So if someone who's naturally low estrogen, they go on the pill, they might be able to put on some lean mass and they might look really good, and they go off of it. And the thing with the pill, it's shutting off the communication between your brain and your ovaries. So whatever issue was there before, it's going to be there when they come off. So if a woman with PCOS who's not ovulating, she comes off the pill, she's not going to be ovulating then either. And I see Cass in the wings, which means I'm probably out of time.